An altered mental status in a child can be the reason for the emergency call. Let's say mom calls 911 and says the baby just isn't acting right. It could also be a sign or a result of the initial reason for the emergency call. A patient with a diabetic condition who then becomes unresponsive. In either case, we're going to treat any life threats to airway, breathing, oxygenation, or circulation that are associated with the altered mental status. In our pediatric patient, we're going to be checking the blood glucose in the heel. We're going to do a heel stick. Unlike the adult where we do a finger stick, we're going to take our lancet and we're going to prick the heel of our child patient. The heel is a less sensitive area, so it'll cause a little bit less pain for our pediatric patient. It's still capillary blood, so we'll be able to get an accurate blood glucose reading by doing a heel stick. A drowning can occur in any amount of water. It doesn't necessarily have to be a swimming pool, a lake, or an ocean. It could range anywhere from the ocean, a bathtub, or a bucket. The main cause of death in infants or children who are submerged is not the aspiration of fluid, although it can occur in some patients, but it's actually the hypoxia that occurs secondary to the glottic closure reflex that occurs when the water comes in contact with the glottic opening. The majority of deaths are from dry drownings, where the person dies from suffocation and fluid doesn't actually enter into the lungs. If you are responding to a drowning emergency, be aware that there could be a possibility of trauma as well as hypothermia. Infants and children are especially prone to hypothermia, but in any drowning emergency, you also want to be alert for secondary drowning syndrome, which is a deterioration that takes place after normal breathing is restored. And this could be anywhere from minutes to hours after the event. In the case of a cold water drowning, you want to be particularly aggressive and persistent about resuscitating a pediatric patient. In response to the cold water, the mammalian dive reflex, which is more pronounced in children, slows down blood perfusion and metabolism. So it's almost like, for lack of a better term, they go to sleep. So our emergency care will be to remove the patient from the water, and be sure the person that's rescuing the patient is properly trained and equipped to perform a water rescue. We're going to remove the child's clothing, and we're going to provide passive warming with blankets and turning up the heat in the back of the truck. We're going to provide positive pressure ventilation with a bag valve mask, as well as supplemental oxygen, and provide CPR as needed. If we suspect hypothermia, we're going to attach the AED and let the AED monitor and deliver a shock if necessary. Fevers in children, and fever in children, they consider it to be 104 to 105 degrees Fahrenheit. That would be concerning. Some causes of the high temperature could include infection, including meningitis, and heat exposure for being from being left in a hot car or outside in a hot environment. The degree of the temperature isn't always the greatest concern, but how quickly the temperature spikes is important. If the temperature rises rapidly, the child may suffer a febrile seizure, but not all high temperatures will produce a seizure. So emergency care is going to be to lower the body temperature, remove excess layers of clothing. If the fever is a result of the environment, we're going to conduct cooling if the core temp is excessive. We don't want to apply ice packs to the child because that could drop their core temp too quickly and then cause them to begin shivering. If the body gets cooled down too quickly, not only does it cause shivering, but it could also cause the brain to overstimulate, which could produce a seizure in the child. So to treat a child that's been exposed to heat, we're going to wrap them in tepid towels. So just room temp soaked towels, and try to draw the heat away from their core. We don't want to use ice packs. In meningitis, the lining of the brain and spinal cord, the meninges, are infected by either a bacteria or a virus. The infection itself can be rapidly fatal, so it needs to be treated in a timely and appropriate manner. If you have a child that's younger than 3 months old, um, if they have a fever, we would consider it highly suspicious to be meningitis until it's proven otherwise. Some of the assessment findings of meningitis in children could include a recent ear or respiratory tract infection, high fever, lethargy, irritability, or vomiting. Children generally don't present with headaches or stiff necks, um, but they are lethargic and they don't want to eat. Movement for the child is painful, so the parents may report that the child cries every time we pick them up. There also may or may not be a rash present on the child's body. Gastrointestinal disorders like diarrhea, which is characterized by frequent watery bowel movements, is often caused by a GI infection, but it can also come from other illnesses or changes in diet. The most common cause of diarrhea in children is gastroenteritis, which is an infection of the GI tract, and it's the leading cause of dehydration in young children. The child may also be suffering from appendicitis, the inflammation of the vermiform appendix. We most commonly see this in young adults. Acute appendicitis is going to be the most common surgical emergency that you encounter in the field. Um, mostly in older children and young adults. Appendicitis is going to present with diffuse crampy pain surrounding the umbilicus. The patient may be nauseous or vomiting, and sometimes they'll run a low-grade temp. The pain then becomes localized to the right lower quadrant, but not always. Once the appendix actually ruptures, the pain again becomes diffuse and the patient can become critically ill. Um, they start displaying signs of hypoperfusion and they go into septic shock. Emergency care is going to be placing the child in a position of comfort, usually with the knees flexed to the chest um, on their back. If they're vomiting or if they're nauseous, you can flex their knees to the chest and place them on their side and then transport and consider an ALS intercept. Poisonings constitute a large number of emergency runs for PDs, and that's because kids are inquisitive. They're always moving around. If they see a shiny object or something new, they like to put it in their mouth. The greatest incidence of poisoning occurs in children between 1 and 2 years of age, and poisonings in children less than 4 years of age account for about 46% of all poison exposures. A thorough secondary assessment is going to be critically important because poisons can enter through different routes: ingestion, inhalation, absorption, and injection. We want to gather as much information as possible about the type of overdose prior to transporting the patient to the hospital. Our emergency care is going to focus on the effects of the poisoning on the patient rather than the specific poison itself. If the child has ingested a poison and you're able to identify what the poison is, your best resource is going to be poison control. Contact poison control and give them as much information as you can, and they'll advise you as to what treatments should be provided to the patient given the specific poison. And then call in your entry notification to the emergency department and let them know that you spoke to poison control and that you've initiated the treatments as recommended by poison control. If the child is alert and responsive, continue to monitor. Continue to monitor their airway and monitor for any signs of aspiration. If the child is responsive, you want to transport them on their left side in case they do vomit, so an airway obstruction doesn't develop. If the child is unresponsive, establish and maintain an open airway and be prepared to suction. You can place them on oxygen at 15 liters per minute. And as you're transporting, you want to contact ALS for an intercept along the way. An apparent life-threatening event involves apnea, where they stop breathing for a period of time, skin color change, changes in muscle tone, and unexplained choking or gagging. Apparent life-threatening event is defined as an episode that's frightening to the observer and that's characterized by some combination of apnea, color change, a marked change in muscle tone, choking or gagging, and in some cases, the observer fears that the infant has died. The symptoms of an apparent life-threatening event are often transient, meaning they go away after a minute to a couple of minutes. Our emergency care for an infant that's exhibiting any of the transient signs is going to be an immediate transport um, to an age-appropriate facility for further evaluation. Sudden infant death syndrome, or SIDS, is the sudden and unexpected death of an infant in which the autopsy fails to identify a cause. SIDS applies to SIDS applies to an infant under 1 year old. The leading cause of death among infants between 1 month and 1 year old, with a peak instance at 2 to 4 months. SIDS is going to be the post-mortem diagnosis, not a diagnosis that can be made in the field. If it's a SIDS death, it's considered to be a potential crime scene rather than a medical scene. So you want to be very careful not to convey any suspicion that the parents or the caregivers may be responsible for the child's the child's condition. In a SIDS case or a suspected SIDS case, EMS care is going to revolve around resuscitation unless obvious and apparent signs of death are present. So immediately try to resuscitate and attempt aggressive resuscitation of the infant, the exceptions being rigor mortis and dependent lividity. If you do find rigor mortis and dependent lividity, you want to leave the infant in the position found and contact the authorities. The reactions of family members to the SIDS incident will be varied. One of the most common immediate reactions of the caregivers to SIDS is shock and disbelief. This may cause the family members to become immobilized or incapable of making decisions. It may also cause them to act as if they're cold and unfeeling. It's not that they don't care, it's just that they're having a hard time facing reality. So dealing with the extreme reactions may be difficult for the provider. Some caregivers may physically act out their emotions, resulting in hysteria, crying, or wailing. Or the caregivers may be confused and overwhelmed with guilty feelings, and unfairly venting their anger and frustration on each other or to the provider. You are there to give emergency medical care, and not to become personally involved. But you still have to understand that these caregivers and family members are also going to need your care. Um, so we're not only providing care for um, the infant, we're also providing psychological and emotional care for the parents. Trauma in pediatric patients is the number one killer of children aged 1 to 14. About 50% of the trauma deaths occur within the first hour after the injury. So, in dealing with pediatric trauma, you want to consider both the mechanism of injury as well as the anatomy of the pediatric patient when you're forming your index of suspicion in regards to the injury. Blunt trauma is the most common injury in children. Quite frequently, a child will be severely injured but display no early obvious signs. So while you're at the scene, you want to try to reconstruct the incident and try to understand the mechanism of injury. When you're assessing the mechanism of injury during the scene size up, remember not only to look at the vehicle or the other object that caused the trauma, but to look at the size of the patient in relation to what they came in contact with. Some common patterns of injury to expect in infants and children. Um, if it was an unrestrained child in a car, they're probably going to suffer head and neck injuries because the child is proportionately larger than the adults, and it's likely to come in contact with the interior of the car. The restrained child passenger will probably suffer abdominal or lumbar injuries from the stress applied by the seatbelt during the accident. If the child is struck while riding a bike, head, spine, and abdominal injuries occur because these areas are the same height as the bumper. Head injuries are common in children, and that's again because of the relatively larger size of the child's head compared to the body. The weight of the head will carry it forward in advance of the body. The head is often the first thing to strike an object. Chest injuries are also seen because infants and children have ribs that are more pliable than the adult, and while they're less likely to suffer rib fractures, they're more likely to sustain internal damage, injuries to the lung and the heart wall, because the ribs don't protect these structures very well from forces that are applied to the chest. Presentations of injuries to the extremities are the same for infants, children, and adults. Assessment and treatment is going to be essentially the same. The abdominal muscles in the infant and child aren't as well developed, and they don't offer a lot of protection from blunt trauma. So if the patient's deteriorating rapidly without external signs of injury, that would heighten the suspicion for hidden abdominal injuries. And then lastly, burns. Infants and children that are under the age of 5 suffer more severe consequences from burns than older children and adults. Younger children are at an increased risk of hypothermia, fluid loss, and other effects of the burn. And that's partially because of their greater skin surface in relation to their body mass. In our pediatric trauma patient, we're going to take the same steps as the adult. We'll establish inline manual stabilization using a jaw thrust maneuver to open the airway. Suction is necessary. Provide supplemental oxygen as needed, or positive pressure ventilation. We'll provide spinal motion restriction, where we'll apply the cervical collar and then immobilize their head on the stretcher to prevent lateral movement. If the car seat that the child was sitting in, was also involved in a motor vehicle crash, you don't want to use it to transport the child. Once a car seat's been involved in a crash, the structural integrity is in question. You want to remove the child from the car seat and transport them in a PD mate, which attaches to the ambulance stretcher, and then provide spinal motion restriction using the cervical collar and securing their head to the stretcher to prevent lateral movement. This is a child immobilization device that attaches to the stretcher. So if the child had a head injury and you didn't have the appropriate sized extrication device, you could wrap the child in this and it attaches to the stretcher. We don't use these in Massachusetts, but you could use the PD mate, which will work to keep the child supine. It's basically like a flexible car seat, but it attaches to the stretcher at 2 points. So the PD mate is secured to the stretcher, and the PD mate has shoulder straps that come over the device and keep the child inside the device so they don't go flying out if there's a crash. The straps that are on the stretcher are designed to accommodate an adult, not a child. So PD mate or a child transport device are required to be in the ambulance. In the pediatric chain of survival, um, the pediatric chain of survival that the American Heart Association has, the first link in the chain is prevention of the arrest. So injury prevention in the child um, is extremely important because injury is the leading cause of death and disability in children and adolescents. The term injury is not synonymous with accident. Unlike an accident, a childhood injury is an understandable, predictable, and preventable occurrence. So pediatric injury prevention is one of the most important and most challenging aspects of child health care. Young kids inherently lack mature decision-making skills to protect themselves from injury, while some older children and adolescents engage in risky behaviors. Preventable childhood injuries account for about 44% of all deaths in individuals aged 1 to 19. In 2002, data's a little bit old, but in 2002, unintentional injury resulted in the death of about 20,000 children, adolescents, and young adults. The estimated number of children who are abused and or neglected in the United States, it's kind of shocking. There's estimates that range between 500,000 and 4 million cases annually. Child abuse has been the only major cause of infant and child death to increase over the last 30 years. Physical abuse takes place when improper or excessive action is taken so as to injure or cause harm. Neglect is the provision of inadequate attention or respect to someone who has a claim to that attention. So there are some general indicators of abuse and or neglect. There could be multiple abrasions, lacerations, incisions, bruises or broken bones, multiple injuries or bruises in various stages of healing, injuries on both the front and the back of the child's body, unusual shaped wounds like cigarette burns, fearful child, injuries that don't match the mechanism of injury as described by the caregivers, untreated chronic illnesses like if the child has asthma, um, no medications are seen in the home for the child. Malnourishment and unsafe living environment, delay in reporting injuries, or implausible explanations like a 6-month-old pulling a pot of boiling water off the stove and onto himself. EMTs and first responders are mandated reporters in the Commonwealth of Massachusetts. If you suspect child abuse, the form that you fill out is 51A. You fill out form 51A and you leave the copy with the patient at the hospital, and then the hospital will follow up with social services, but the EMT or first responder also has to call um, the child abuse hotline and make a verbal report within 24 hours of filing the 51A. Typical accidental bruises are usually found on the lower arms, the knees, the shins, the iliac crests, the forehead, and under the chin. If you have a suspicion of child abuse, you don't want to ask the child what happened in front of the suspected abuser. Um, you want to ask the caregivers what happened, but you don't want to question them about the abuse. Um, and you do have to report it, both written and verbally. If you're dealing with suspected child abuse, and the call came from outside the family, the caregivers may resist. Entry should be handled by the police. If you're asked to help the child, try to calm the caregivers and indicate that you're there to help. When you're dealing with the child, you want to speak softly and call the child by their first name. Don't ask the child to tell what happened while they're still in the crisis environment. If you have a reason to suspect abuse, you'll perform a head-to-toe rapid assessment for evidence of and any clues to intentional injury. After administering emergency care, you want to tell the caregivers that the child should be taken to the hospital for further care. In a separate room from the child, ask the caregivers to describe how the injury occurred. This will allow the hospital staff, social worker, and others later to compare the child's account with that of the caregivers. You don't want to allow the child to be left alone with the suspected abuser, which may allow for further abuse or intimidation. And just remember that we are federally mandated um, to report any suspected child abuse. And when you're documenting it, you want to be objective and not subjective. Emergency Medical Service for Children, or EMSC, is a federally funded program that's designed to ensure that all children and adolescents have access to appropriate care in a health emergency. This was established, EMSC was established in 1984, and it's provided grant funding for all 50 states, District of Columbia, and the 5 United States territories. The concept of family-centered care was introduced in 1987. Um, this is community-based coordinated care team for children with special healthcare needs and their families. Family-centered care suggests that healthcare providers acknowledge and make use of the family's knowledge of their family member's condition and make use of the family's ability to communicate. Although the concept of family-centered care isn't new, um, it's new to EMS as an initiative. Um, the major principle of family-centered care is the need for a comprehensive understanding of normal growth and development, which enables the EMS provider to better anticipate the physiological and emotional needs of the child who's affected by an injury or an illness. Taking care of a critically ill or injured child is one of the most challenging facets of an EMS career. The death of a child has a profound effect on each and every one of us. As EMS providers, we are not comfortable with kid calls. We don't see a lot of pediatric calls. We don't deal with a lot of pediatric patients because kids are generally very healthy. Kids bounce back very quickly from injuries. Um, we don't deal with a lot of PD patients. So that leads us with stress and anxiety because we have a lack of experience in treating kids. We have a huge fear of failure, Some ways to alleviate stress are to learn skills and practice using the equipment with children. Your best defense against anxiety is going to be preparation and practice, practice, practice. Focus on the task at hand while you're treating the infant or the child. Temporarily separate how you feel from what you have to do. And that completes the rest of pediatrics. All right, we finished with pediatrics. Now we're going to move into chapter 35, geriatrics. When we're assessing and managing a geriatric patient, um, we have what's known as the GEMS diamond. The GEMS diamond was created to help you remember what's different about the older patient. So keep the GEMS diamond in mind whenever you go to a call that involves an older patient. So obviously the G in the GEMS diamond stands for geriatric. One of the first things you should think of when you go on a call involving an older patient is that older patients are different and they may present atypically. There are changes that occur with age. Um, we want to be sure to treat the older patient with respect and dignity. E is the environmental assessment. The environment may contain clues to the cause of the emergency. So some things that we would look at on the environmental assessment is the home well kept and secure? Are there any hazardous conditions like poor lighting, throw rugs, poor wiring, or broken windows? Is the home too hot or too cold? Taking into account that an older person's sensitivity to temperature may be diminished. M is the medical assessment. Older patients tend to have a variety of medical problems and they may be on numerous prescription as well as over-the-counter medications. So be sure to obtain a thorough medical history. Lastly, S is our social assessment. Older people have less of a social network due to the death of a spouse or moving away from family members or friends. This can lead to depression. Additionally, the older person may need help performing activities of daily living, but they may not have anyone to help. So try to find out if the patient has sufficient social support to care for both their physical and emotional needs. Next, we're going to talk about effects of aging on the different body systems. Age-related changes in physiology begin around age 30. Aging is not a disease, but age-related changes can make the body more vulnerable to both disease and injury. So we're going to look at some of those changes now. We know that people are living longer with chronic illnesses. The elderly population constitutes a large percentage of our EMS patient volume. Most elderly patients have a combination of different disease processes in various stages of development. As the body ages, there are fewer reserves with which to combat those diseases. So ultimately, it's going to contribute to the instance of acute medical and traumatic injuries. With age, degenerative processes affect the ability of the heart to effectively pump blood. Calcium gets progressively deposited in those areas of deterioration, especially around the valves of the heart. Damages to the valves of the heart from this degeneration can result in a variety of problems. The changes in the heart can lead to decreased cardiac output and reduced ability of the body to compensate. Stenosis is a narrowing of the valve opening which restricts the flow of blood through the heart. It may reduce blood flow through the heart to the point where the demands of the body are not met. In addition, if the valve can no longer seal correctly, blood may be forced back through it, causing a backup of blood in the lungs, which will result in pulmonary edema. Cardiac hypertrophy is a thickening of the heart walls that leads to a decrease in stroke volume of the heart. This decreases the efficiency of the body's compensatory mechanisms in the face of stress that could be brought about by an illness or an injury. Dysrhythmias are irregular contractions of the myocardium secondary to an electrical disturbance in the heart. Arteriosclerosis is a hardening of the arteries. It causes the arteries to become stiff, and it increases the pressure that the heart has to pump against. Compounding the stiffening of the arteries is a drop in baroreceptor sensitivity, which makes it harder for the older patient to regulate their blood pressure. This often leads to a condition that's known as orthostatic hypotension, which is a 10-point drop in the systolic blood pressure and a 10-point elevation in the heart rate when the patient goes from a lying to a standing position. And that's what usually causes the syncopal episode at 3 o'clock in the morning, when the patient gets up out of bed too fast and they fall down on the floor on their way to the bathroom. Unfortunately, almost every component of the respiratory system experiences some type of deterioration over time. These changes in the aging respiratory system occur mainly as the result of alterations in the respiratory muscles and the elasticity and recoil of the thorax. The muscles that are used for respiration will actually decrease in size and strength. Calcium deposits begin to form where the ribs join the sternum, which causes the rib cage to become less pliable. With aging, the number and the strength of smooth muscle fibers that support the smaller airways also decrease. The result is going to be turbulent airflow, which diminishes airflow to the terminal alveoli during inspiration and can also result in air trapping during exhalation. The cough reflex, which helps eliminate inhaled particles from the airway, may not trigger as readily. And because of the weakening of the muscles, the coughing that does occur becomes less forceful. The cilia, or the hair-like projections that line the airway and help to remove foreign particles trapped in the mucus lining, are less able to move the material up and out of the airway. The nervous, the nervous system becomes impaired by the normal effects of aging. As the brain neurons degenerate, waste products can collect in tissues, causing abnormal structures called plaques and tangles to form. As these changes take place, the overall ability of the brain to operate as it did when it was younger becomes increasingly impaired. The ability of the brain to monitor and regulate vital functions, such as the rate and depth of breathing, heart rate, blood pressure, and core body temp, can become deranged and not operate within the same efficiency during stressful times as they do in the younger patient. The mass of the brain actually decreases, and the amount of cerebral spinal fluid that occupies the extra space in the skull increases. Because of changes that occur in the brainstem and other regulatory centers of the brain, the ability to perceive hunger and thirst are also altered. Sensory perception also diminishes over time, including our everyday senses like auditory, visual, and olfactory, which is how things taste. Elderly patients are at a risk for cataracts, glaucoma, macular degeneration, which affects the ability to see in the center of the visual field, and retinal detachment, which occurs when the retina detaches from the tissue behind it. Neuropathy is abnormal function of the motor, sensory, and autonomic nerve tracts. It could be diffuse, involving multiple neurons and nerve tracts that affect many parts of the body, or it could be focal neurons, which affect a single specific nerve and part of the body. This is more common in our diabetic patients, our elderly diabetic patients, where they suffer from peripheral neuropathy, meaning that their sense of sensation to the periphery or the extremities is diminished. Generally, the findings of neuropathy would include pain, numbness, um, muscle weakness, or absent pain perception. Physiological changes can reduce the appeal of food and the ability to absorb nutrients. Slowing in the GI tract results in constipation and fecal impactment. Oh boy, fun things. So we already talked about the reduction in the sense of taste and smell. So that's going to result in decreased food enjoyment and decreased PO intake. Deterioration of structures in the mouth, as well as periodontal disease, can cause a loss of gum tissue, can cause pain, and consequent tooth loss. With age, there's a decrease in salivary flow because there's degeneration of the salivary glands. Chronic heartburn, which usually results from a loss of smooth muscle contraction in the esophagus and stomach. As we age, the liver decreases in size, weight, and function, which decreases the liver's availability to aid in digestion and to metabolize certain drugs. In the GI tract, food takes longer to move through the system, and that's a result of the degeneration of the lining of the small intestines. Nutrients aren't as readily absorbed, which then further contributes to the malnutrition. Constipation is common because of smooth muscle contractions of the large intestine. The smooth muscle contractions of the large intestine start to diminish. In some patients, there's degeneration of the rectal sphincter muscle, which can cause a loss of bowel control. As the endocrine system ages, both hormone levels and target organ response become altered. So both levels of hormones and blood pressure can increase, which will contribute to the development of hypertension. The levels of hormones that help to regulate the body's fluid balance also become deranged and can contribute to a fluid imbalance, which will further affect blood pressure. The target organ response to sympathetic stimulation in the heart and vascular smooth muscle decreases. The net effects of these endocrine changes are seen in the clinical syndromes of hypertension and orthostatic hypotension that are very characteristic of the elderly. In addition, the aging process produces mild carbohydrate intolerance and a minimal increase in fasting blood glucose levels caused by a drop in receptor cell responsiveness to insulin. So as the patient ages, they slowly transition into a type 2 diabetic. So collectively, those changes in the endocrine system may cause elevation of blood glucose levels, especially after eating a large meal. The musculoskeletal system becomes affected by osteoporosis and loss of skeletal muscle mass. Osteoporosis makes the bones more brittle and susceptible to fractures, and it slows the healing process. The discs located between the vertebrae of the spine start to narrow, which causes that characteristic curvature of the spine that's seen in 2 out of every 3 elderly patients. The curvature, which is known as kyphosis, is seen along the entire spine, but it's more pronounced in the thoracic vertebrae. Um, the joints also begin to lose their flexibility. The cartilage that covers the articular surfaces where joints meet starts to thin out, and the synovial fluid that surrounds the joint starts to thicken. The ligaments that provide joints with stability start to weaken as well. So the effects are going to be diminished range of joint motion, possible pain with movement, and an increased risk of joint injury. Decreased renal or decreased liver and kidney function put our elderly patient at risk for a toxicological emergency. The kidneys become smaller in size and weight because of a loss of the functional parts of the kidney, the nephrons. The loss of nephrons can reduce the actual weight of the kidney by about 1/3 of the normal weight. The effect is a decrease in the surface area of the kidney that's available to filter blood. The arterial system supplying the kidneys is also subject to the changes in the cardiovascular system, which results in a drop in renal blood flow. So in combination, these changes result in a lesser amount of blood per minute passing through the kidneys for filtration. In addition to that, it also decreases the available filtration surface area. And we know the kidneys play a vital role in fluid and electrolyte balance. Kidney malfunction or kidney injury typically leads to a secondary disturbance in fluid and electrolyte distribution. There's a lot of drugs, including antibiotics, that get filtered out by the kidneys, and the elderly will commonly suffer from drug toxicity if they accidentally take too much medication or if they take it too frequently. With age, the skin begins to thin. It's more easily injured and it provides a less effective barrier to the environment. The subcutaneous layer of skin actually begins to deteriorate, and then less attachment tissue exists between the dermis and the epidermis. Our elderly patient's skin is much more prone to injury than a younger person, and that's because replacement cells are produced less rapidly. So wounds take more time to heal, and the skin is slow to replace itself. Because the elderly patient's thermoregulatory system is aging, less perspiration is produced, and then the sense of touch becomes dulled. And the last effect of aging on the skin is there's a diminished effectiveness of the skin as a protective barrier in keeping microorganisms out of the body. The way diseases present and progress in the elderly are affected by the age-related physiological changes. So we're going to talk about some special geriatric assessment findings. Elderly patients are at a higher risk for a silent MI, which may present as generalized weakness, fatigue, and confusion. In a younger person, a lack of oxygen and other nutrients to the heart typically produces that classic chest discomfort. In contrast, as a result of decreased pain perception, geriatric patients experience what's known as a silent heart attack. This means that the elderly heart attack patient may have no or very little chest discomfort. Instead, the geriatric patient suffering a heart attack usually presents with very general complaints like weakness, fatigue, confusion, dizziness, nausea, vomiting, abdominal pain, or syncope. Trouble breathing is also a very common initial complaint. If you find nitroglycerin at the scene, it's going to clue you into that the patient may have a history of heart problems. Emergency care is going to be providing oxygen to keep this at around 94%, assessing their vital signs, and assisting the patient with administration of their nitro if their blood pressure is greater than 120 systolic, and transport to the hospital with an ALS intercept. Our telltale signs of congestive heart failure include edema or swelling of the lower extremities, altered mental status, fatigue, crackling when you listen to the lung sounds, indicating that there's fluid, dyspnea, tachypnea, and anxiety. Congestive heart failure is also very common in the geriatric patient. It can be a chronic condition that the patient may tell you about during the history taking, or it may have an acute onset and be the cause of the reason for the patient summoning EMS. Even though congestive heart failure is caused by cardiac disease, it presents differently than a heart attack does. It's caused by a heart that becomes weakened over time as a result of the changes in aging, as well as hypertension, arteriosclerotic disease, and heart valve damage. As a result of these cardiac changes, the heart can no longer pump as effectively, and the blood begins to cause a backup in the peripheral blood vessels, as well as the vessels in the lungs. And that causes the fluid to leak out of the vessels. So you'll see that edema in the lower extremities with the patient sitting upright and you have them turn their head at a 45-degree angle. You may see some jugular vein distension or JVD. Crackles when you listen to the lung sounds, probably some wheezing as well. Our emergency care, you could definitely apply CPAP to a patient that is in acute CHF. You could also use positive pressure ventilation. Ultimately, what we're trying to do with those two strategies is to blow open the alveoli and force the fluid out of the alveoli back into the interstitial space and thereby creating a space for the gas exchange to take place at the alveolar level. So here's our dyspnea or shortness of breath and all the different things that could cause the elderly patient's shortness of breath. We'll start with pulmonary edema. Pulmonary edema can have a gradual or a sudden onset. Pulmonary edema typically results from the failure of the heart to pump. So it could be the underlying history of CHF, could be a heart attack, or it could be valve damage. In pulmonary edema, the left ventricle starts to eject less blood than the right ventricle. Now, normally, the ventricle should eject the same amount of blood simultaneously, but because the left ventricle is ejecting less blood than the right, it results in an excessive pressure in the vessels in the lungs, and the fluid begins to leak into the space between the alveoli and the capillary, causing the pulmonary edema and resulting in an inadequate gas exchange and respiratory distress. Findings are going to include severe respiratory distress, especially lying down. That's known as orthopnea. Altered mental status because they're hypoxic, coughing with a possibly blood-tinged sputum, as well as other signs of congestive heart failure. Again, in pulmonary edema, you could place the patient on CPAP to blow open the alveoli and force that fluid into the interstitial space to improve the gas exchange at the alveolar capillary level. Pulmonary embolism is a blockage in the artery of the lungs. This is a respiratory emergency that we see more frequently in elderly patients. The pulmonary embolism may present with a very sudden onset of dyspnea, as well as chest pain that's localized and doesn't radiate. So this pulmonary embolism occurs when a blood clot breaks free from veins of the lower extremities or the pelvis, and it gets transported back through the right side of the heart. From there, the clot eventually lodges somewhere in the arteries of the lungs, and this results in a poor oxygen carbon dioxide gas exchange in the alveoli because that clot prevents blood from flowing through the capillaries. So because the patient has an inadequate exchange of O2 and CO2, it's going to result in respiratory distress. And then that degree of respiratory distress depends on the size of the clot. With a large clot, the blood can't make it from the right side of the heart to the left. The patient will be hypotensive. So we're going to assess and treat the underlying respiratory issue and transport with an ALS intercept. Pneumonia results as an infection of the lungs by a bacterium, a virus, or another pathogen. Common in elderly patients because of the diminished ability of the respiratory system to fight off infections. Um, Elderly patients may also present with aspiration pneumonia, which results from an accidental aspiration of food or vomit into the lungs. On exam, patient will present with an increased respiratory rate, progressive worsening of shortness of breath, congestion, a cough with some sputum production, possibly wheezing, general overall sick-looking appearance, weakness, weight loss, and they may also display an altered mental status. Unlike the adult patient, when an adult patient has pneumonia, they usually present with a temp, and that's because the body's sending out white blood cells to fight off the respiratory infection. In elderly patients, because body systems are starting to age and break down, elderly patients generally don't present with that classic temp like the younger adult does. Instead, geriatric patients will present first with an altered mental status as our first clue that they have an infection cooking. Chronic obstructive pulmonary disease is a disease complex that includes a number of individual pulmonary disease processes, typically chronic bronchitis and emphysema, that result from gradual deterioration of the pulmonary structures. The effects of COPD cause a disturbance of the gas exchange in the lungs. Usually our COPD patients are going to be complaining of respiratory distress. You'll see them using accessory muscles when breathing. They may already be on home oxygen. Emergency care for COPD would be assisting the patient with their rescue inhaler, albuterol or Atrovent, and possibly giving the patient a small volume nebulizer of albuterol. Stroke is a common reason for an altered mental status in the geriatric patient. Stroke occurs when a blood vessel in the brain becomes blocked by a clot, which obstructs blood flow, or ruptures and allows blood to accumulate in the brain tissue itself. Because the skull doesn't expand, the pressure within the brain, which is known as intracranial pressure or ICP, sharply increases while the nerve cells in the brain start to die or malfunction because of that increase in ICP. The level of carbon dioxide in the brain also begins to increase, which then causes the cerebral vessels to dilate and further increase intracranial pressure. The extent and the location of the stroke affects the severity of the altered mental status. The patient could be slightly disoriented up to totally unresponsive. If the patient has a massive stroke, it could lead to death in a matter of minutes. Aside from the altered mental status, we may see some inequality of pupils, slurred speech, abnormal speech pattern, or nonsensical speech, speaking uh, that doesn't make sense. Sensory loss, muscle weakness or paralysis, usually to one side of the body, alteration in respiratory pattern, and a high systolic blood pressure, which gradually becomes normal or hypotensive. Our emergency care is going to be to do the fast ED assessment. And if the patient's last known well time was less than 4 hours, they may be a candidate for TPA, um, the antithrombolytic therapy, or if they're on blood thinners, they would not be a candidate for TPA, but maybe they would be a candidate for mechanical clot removal. So we would transport the patient to a stroke center, and we would call a stroke alert into our entry notification. TIA is the mini stroke, and the symptoms are completely reversed within 24 hours of the onset, but it's usually sooner. With a TIA, there's no permanent neurological dysfunction, and it's caused when blood supply to an area of the brain is temporarily occluded. Signs and symptoms are going to be the same as a stroke, and the treatment steps are the same as I talked about in stroke. A seizure is sudden and temporary alteration in the mental status, which is caused by massive electrical discharge in a group of nerve cells of the brain. Common causes: cardiac arrest, low blood sugar, tumors, head trauma, stroke or TIA, infection, or electrolyte imbalance. Emergency care will be the same as treating a younger seizure patient. We don't want to restrain the patient while they're actively seizing. We want to move any unsafe objects out of the way, maybe throw a couple pillows or blankets down on the floor so they don't bang their head into anything. After the seizure passes, place the patient in the recovery position to help prevent aspiration if they're unresponsive and there are no signs of trauma. Syncope or simply passing out can have a number of underlying causes in our elderly patient. It's a temporary loss of responsiveness. Usually it reverses once the patient's laying down. It's caused by reduced blood flow to the brain, but it can also be a sign of a number of underlying diseases. Um, could be a side effect of a medication or a reaction to a strong emotion. Emergency care will be oxygen as needed and supportive care en route to the hospital. Hyperglycemic non-ketonic syndrome is a diabetic complication that's more common to the elderly patient with type 2 diabetes. This is a condition where the blood glucose level elevates because of inadequate insulin secretion or inadequate action on target cells. There's enough insulin being secreted to keep mass amounts of fat from being metabolized for energy. So that limits the amount of ketone bodies that are formed. The glucose level does raise high enough to cause excessive urination as well as severe dehydration. Assessment findings are going to include polyuria, which is excessive urination, and polydipsia, excessive thirst. Our care is going to be supportive or routine patient care. Elderly patients are at a higher risk of toxic or adverse reactions to drugs. They're at a higher risk than younger patients. The geriatric population takes about 1/3 of all prescription medications, and they also buy the greatest number of over-the-counter medications. Since elderly patients tend to have a number of coexisting diseases, they're at a greater risk for drug interaction from prescription drugs. Certain medications, whether they're taken individually or in conjunction with others, have a tendency to alter the patient's mental status, cause a syncopal episode, or even unresponsiveness. Drug toxicity could also be caused by an error in dosing. Um, the elderly patient may take the wrong dose because of poor eyesight, confusion, forgetfulness, or muscle memory, where they tend to take the medication after the physician discontinues it and it's no longer needed. Dementia is a condition that results from the malfunctioning of normal brain activity. It's chronic, irreversible, and it can be severely worsened by infection, medication change, trauma, or other acute conditions. Mental processes normally undergo changes as the person ages, but approximately 15% of those over age 65 develop severe dementia, which results in a profound disturbance in mental functioning. Delirium can also result in an alteration in mental status, but unlike dementia, which is a chronic condition, delirium presents with a more recent and sudden onset. Delirium is most often described by family members as starting abruptly, and it may present with delusions as well. Dementia, chronic and progressive, delirium, acute and often reversible causes. Really, the best example I can think of for delirium would be the elderly patient with a UTI. Once they start the antibiotic course for the urinary tract infection, the delirium goes away. Characteristics of dementia are chronic changes in cognition, loss of short-term memory, decline in intellectual abilities, decline in judgment, math ability, and abstract thought. Dementia can be caused by medications, especially analgesics, sedatives, um, tranquilizers, as well as those taken to reduce blood pressure or ease the symptoms of Parkinson's. Delirium is not a medical emergency in itself, um, but it's an indication that there's a significant disturbance in some body system. So as such, the additional physical findings, like your vital signs, are going to reflect the underlying pathology that's causing the delirium. Management of delirium, as for dementia, is primarily supportive, so we'll provide routine patient care. We're still going to do a full assessment. Um, the delirium could be caused by a reversible condition, which we can treat. For example, if we do a finger stick and the patient is hypoglycemic, we can administer oral glucose, and that would reverse reverse the condition, that would reverse their delirium. So we want to target our specific management um, based on our assessment. Alzheimer's disease is believed to affect more than 2 million Americans, and to be responsible for more than 100,000 deaths each year in the United States. The disease doesn't directly cause death, but it can cause patients to stop eating, become immobile, and then eventually become subject to numerous infections. The cause is presently unknown, but it's believed to be a disease of nerve cells in which brain cells degenerate and die. Um, Alzheimer's is progressive and global in nature, involving the central nervous system. It is commonly a disease of the elderly, but it can affect people as young as 40 years old. Alzheimer's disease causes confusion, emotional depression, irritability, and even violence between lucid intervals. The patient progressively loses appetite and an ability to care for their own needs. Um, Eventually, the patient doesn't recognize loved ones. Um, Alzheimer's patients often attempt or commit suicide. Sometimes you may find that the patient is very uncooperative or even combative. Sometimes they bite, they spit, and they punch. Just remember the uncooperativeness and the aggression are symptoms of the disease. They're not conscious acts of aggression against you personally. You'll also find that you have to repeatedly inform the patient of the same thing over and over, because their mind isn't able to process, let alone remember what you're saying. So don't take the patient's actions or words personally. Trauma is one of the leading causes of death in the geriatric population. The type of trauma that is seen most frequently in the elderly is blunt trauma from falls. Um, and then behind that are motor vehicle crashes and pedestrians struck by automobiles. Many of the falls that our elderly patients sustain can be prevented. So we want to assess the elderly trauma patient for both causes of the fall as well as the consequence of the fall. Falls account for about half of all the accidental deaths in elderly, and a common cause of head injuries. The environmental factors, remember the GEMS diamond when we assess the environment? Those environmental factors may cause the elderly to fall. They may have stairways without handrails, slippery bathtubs, they slip on rugs. Those are all mechanical falls. Number of medical reasons why the elderly patient falls would be dizziness as a side effect from medication, heart rhythm problems, syncope, low blood pressure, or poor vision. Head injuries are actually harder to detect in elderly patients. Signs of brain injury in an older patient may take days or weeks to develop. And the patient may have actually forgotten the initial injury by the time signs and symptoms appear. Patients over age 65 automatically get a cervical collar as a result of their fall because their bones are more brittle, their spinal column is less stable. Um, when you're doing your trauma exam on a geriatric patient over the age of 65, if they fall from a standing height or they fall out of bed and land on the floor, they automatically get a cervical collar, regardless of whether or not they can recall all the events leading to the fall, and they deny any pain on exam. We're not going to put them on a backboard, but we are going to apply a cervical collar, have them stand and pivot to the ambulance stretcher, and secure their head in a way to prevent lateral movement. Even if the patient falls out of their wheelchair, that's still considered a fall from standing height because their mobility impaired. So their wheelchair is now their new standing height. That only applies if you're going to be wearing your EMT hat and transporting the patient. It doesn't apply to a lift assist where you go to the patient's apartment and help them up off the floor and put them back in the chair before EMS arrives. GI bleeding is common in the elderly patient, and the GI bleed can occur anywhere along the digestive tract, which is basically from the mouth to the anus. It may be obvious or it may be hidden. Um, the term we use for hidden is occult. While GI bleeding is a sign that there's a disease of the GI tract present, the GI bleed is not a disease itself. It can come from the upper GI tract or the lower GI tract. It could be a result of ulcerative disease, inflammation, infection, or an obstruction. Most common assessment finding is going to be abdominal pain. The type, the location, the presentation, the history and associated complaints are going to help isolate the type and source of the bleeding. Some other findings that would support a field impression of GI bleeding would include vomiting blood, red undigested blood in a bowel movement, dark tarry bowel movements, indigestion, an enlarged liver, or jaundice, which is yellowing of the sclera in the skin, which means they have a liver problem. We're going to provide routine patient care. Effects of the aging process also leave the elderly patient at a greater risk of experiencing an emergency as a result of changes in the environmental temperature. The ability of the body to create heat when it's cold or to dissipate heat when it's hot may be impaired not only from the aging process, but also from diseases or medications that the patient may be taking. There's a number of factors that make elderly patients more prone to hypothermia. They have a smaller insulating layer of fat. There's reduced muscle mass, and the body's metabolic rate slows with age. We want to warm the patient up. We want to keep them cold, and use caution when handling a severely hypothermic patient. Remove their wet clothes if they're wet. Wrap them up in warm, dry blankets. Hyperthermia is an equally serious heat-related disorder in the elderly patients. Our elderly patient's core temp can increase more rapidly than the younger patient. So when preparing to treat the patient, you need to keep in the back of your mind or take into consideration the length of time the patient was exposed to the environmental extreme. Our emergency care for the geriatric patient is the same as the adult, only less aggressive. Ice packs behind the neck, on top of the head, and under the armpits are appropriate. We don't want to cool them too fast, because just like our pediatric patients, if we cool an elderly patient down too fast, they could also suffer from a seizure. We know that we're doing our scene size up, mechanism of injury versus nature of illness, and using any scene clues as well as environmental clues. Our primary assessment is going to focus on mental status, level of responsiveness, airway, breathing, and circulation. We need to remember that we have to give our elderly patient more time to process the information when we assess their mental status. In our secondary assessment, this is where we're gathering our vital signs, we're taking our history. Our elderly patients may be vision impaired, or they may be hard of hearing. If the patient is hard of hearing, you don't want to shout to try to communicate with them. Instead, you want to get down on the patient's level and speak slowly in your normal tone of voice so they're able to read your lips. If you start shouting, it starts to convey anger, and the patient becomes more defensive and it's more difficult to get a history. In our geriatric trauma patient, in our secondary assessment, we'll continue on with our head to toe exam if they're unresponsive. If they're responsive and they're able to localize their pain, we can do a focused exam. Also, we want to treat any life-threatening injuries as we find them, just as we would for a younger adult or pediatric patient. For a medical patient, we want to talk to the patient rather than talking to others about the patient. So we want our patient to be the source of most of our information and then get supplemental information from family members or nursing staff. It may be a little bit difficult trying to figure out what their chief complaint is, especially if they're isolated and lonely and they don't have anyone to talk to. They may present with multiple vague complaints. You may need to remove multiple layers of clothing in order to conduct that physical exam. The last thing that we're going to talk about in our elderly patients is mobile integrated healthcare, or MIH. So currently, Cataldo is the largest provider of mobile integrated healthcare in Massachusetts. East Care does have mobile integrated health, but theirs is very, very small. MIH is the use of patient-centered mobile resources in out-of-hospital care. So what they're doing with mobile integrated health is the patient calls a nurse line, they explain their signs, their symptoms to the nurse, and then the nurse contacts the paramedic to go out and do a home evaluation of the patient. When the paramedic gets on scene, they do a Zoom call with the doctor on call. They do labs, point of care testing, vital signs, assessment, EKG, you name it, all that information gets transmitted to the doc. And then basically the doc makes the decision of can the patient be treated in the home by the community paramedic or the mobile integrated health paramedic, or does the patient need to go to the emergency room? Really, mobile integrated healthcare is aimed at bringing healthcare to the patients and to reduce the number of ER visits. It's actually cheaper to send out a community paramedic, an X-ray tech, an ultrasound tech, and have a Zoom conference with the doc than it is to transport the patient to the hospital and treat the patient there. Oops, that's the wrong thing. That's what I wanted to talk about. So mobile integrated health improves the patient's quality of life. It's a collaboration with all the stakeholders, the physician, the nurse, the social worker, elder services. This is used for patients that are frequent users, of 911 as their primary care and have multiple ED visits. There's several different programs or models that are out there. One of those models is ED at home, which I just talked about, um, where the patient's assessed and managed in the home. There are patients that are seen as follow-up. Maybe they have congestive heart failure and they're not medication compliant. So it's cheaper to send out a community paramedic to administer the patient's medications than it is to admit the patient to the ER. So there's a lot of really good things that are happening with mobile integrated health. Texas actually pioneered, and I think they pioneered and really have the best mobile integrated health program, where the paramedics and EMTs that do MIH, it's really full circle. They're dealing with the patient's nutrition, organizing medications, acting as a counselor slash social worker, and a liaison between the doctor. All right, we have finished with chapter 35, geriatric emergencies. So let's take a 15-minute break, and then we'll finish with chapter 36, special patient populations, for tonight. All right, our last topic is going to be our patients with special challenges. The patient's primary care provider or providers, they're usually very well versed in the equipment or the technology that's used, um, but they might not be as well trained in what to do if that equipment fails or if the patient's status begins to deteriorate. So you're going to be working very closely hand in hand with the patient's primary caregiver as you're helping them to troubleshoot the equipment and also provide transport um, to an appropriate facility. 9 times out of 10, when somebody that has medical technology in the home, they're not calling EMS just to say hello. They've already tried all the troubleshooting. They've already tried all the troubleshooting steps that they were trained to do before the patient went home with this equipment. So now they're calling EMS because the equipment's failed, and they may not have a backup. So the patient's going to have to go to the hospital. Special healthcare needs or special challenges can present from anywhere from obesity to homelessness, as well as dependence on medical technology. Medical technology is getting more and more sophisticated, and it's getting a lot smaller, which is great. It's allowing patients to be cared for in the home by their loved ones, but it does make things a little bit more complicated for pre-hospital providers because it's a lot of technology and we have very limited training on how to use it. So really, we have to be resourceful when we're dealing with patients with any type of a disability or any type of home technology. We have to adapt and overcome. So really, creative ways of communicating with your patient, um, ways of calling basically tech support for malfunctioning equipment or even medical control to figure out your next steps and the best course of action for dealing with that patient. So we're going to talk about impairments, birth defects, chronic illness, abuse, neglect, some other causes. Most of this is our review of what we've already gone over, so we're going to hit the highlights. Sensory impairments would include problems with hearing, vision, or speech. Those sensory deficits will make it a little bit more difficult to communicate with the patient, but it's not impossible. So there are some steps that we can take to communicate the patient that has sensory deficits. The definition of deafness is the inability to hear, and this could involve one or both ears. And the patient could be partially deaf or totally deaf. If we have a patient that is deaf or extremely hard of hearing, um, and they don't have assistive devices like a hearing aid, it may be best to write things down. It may make the history taking go a little bit smoother. Um, you can use a pencil and a pen or index card, whatever you have available, and you can communicate with the patient in that manner. Diseases like glaucoma result in an abnormal increase in intraocular pressure that damages the optic nerve, and that leads to peripheral vision loss and eventually blindness. If the patient has an eye injury, it could be caused by a puncture or a penetration or blunt trauma to the face. This type of vision loss is usually acute, but it might not be permanent. It just depends on the degree of trauma that was endured by the eye and the associated structures. Articulation disorders or speech disorders are caused by an impairment of the tongue or other muscles that are needed for speech, and that's called dysarthria. It prevents the patient from pronouncing words correctly. Language disorders can occur when the patient displays an impaired or absent ability to understand the spoken word. This can result from congenital problems in children, hearing defects, or inadequate language stimulation in early life. If you're not able to communicate with the patient because of a language barrier or a language disorder, um, you could try using a picture board, or you could try pointing to various areas on the patient's body and looking for subtle yes or no clues, or looking for other subtle body language clues that the patient may display when you're doing your assessment. If your patient has a hearing impairment, many hearing impaired patients are able to read lips. So you want to try to position yourself so your face is in clear view and the area is adequately lit. If you're not able to obtain that vital information through oral communication, you might need to use written communication to get that vital information. If the patient has assistive devices, such as a hearing aid or glasses, you want to fetch those for the patient and help them put them in, and make sure that the hearing aid is turned on. If the patient is vision impaired, you want to speak clearly and explain what you're doing before you do it. If the patient has a service animal, you if you have patient has a service animal, you do have to transport the service animal to the hospital if the patient requests it. Um, the service animal is not a pet. Um, it's an assistive device, just like a hearing aid. So the service animal, within reason. If it's an emotional support animal, like a peacock, no, we're not going to transport that to the hospital. But if it's a service dog, um, that's completely appropriate to transport with the patient to the hospital. Just remember that it's not a pet. You don't want to have the service animal in the back of the truck and be petting it on the way to the hospital. If your patient has a speech impairment, you want to ask questions in a way that allow the patient to answer in as few words as possible. Avoid finishing the patient's words or statements. That's just going to frustrate the patient, and it's going to worsen the speech impairment. Allow the patient plenty of time to respond to your questions. You can also utilize family members or other communication techniques. Basically, what it comes down to is you never want to pretend that you understood something the patient said when you didn't, because you might miss an important piece of information that would have a huge impact on your overall care and treatment of the patient. Patients with emotional impairments or psychosis tend to struggle with interpreting reality, and they might not communicate effectively with you. Um, or if your patient has an extreme emotional dysfunction like depression or anxiety, they won't be able to focus on your questions. Often, a developmental disability involves the brain and causes an inability to learn at a normal rate. The problem may not be noticed until the child fails to reach certain developmental milestones. Some disabilities that commonly affect the nervous and endocrine systems are Down syndrome, autism, fetal alcohol syndrome, and hypothyroidism. Autism, which is also known as autism spectrum disorder, is a range of neurodevelopmental conditions that are characterized by impaired social interaction, verbal and nonverbal communication, as well as restricted and repetitive behavior. This is due to a combination of both genetic and environmental factors. You might find that the family or the caregiver um, reports that the patient has autism spectrum disorder, um, Asperger's syndrome, pervasive developmental delay, or pervasive developmental delay not otherwise specified. Um, so the patient may not be able to communicate with you. They may have a difficult time reading facial expression, and they may have altered sensations. The Autism Spectrum Disorder Foundation recommends when performing the assessment and providing emergency care or transporting a patient with autism that you move slowly during the physical exam, beginning with the feet and working your way to the head. Explain what you plan to do in advance of performing the exam. Explain where you're going and who'll be with you and what they're going to see. When you're speaking to the patient with autism, you want to speak using simple terms and language and a calm voice, giving the patient plenty of time to respond to your questions. It's not uncommon that there's a 3 to 4 second delay after asking a question. You can also ask the caregiver the functional level of the patient. So then you can tailor your questions and ask the appropriate level of questions and provide appropriate explanations. If their caretaker is present, have the caretaker go to the hospital with you and have the caretaker ask those questions that are related to your assessment. We're going to rely heavily on our patients' caregivers, um, and we also want to try to compare the patient's behavior to what the caregivers say is normal for them. We're also providing clear explanations as well as treating all of our patients with respect. Some impairments can be obvious when you first encounter the patient. Others, like hearing and vision impairments, may not be as readily evident. So we always want to approach the patient as if all sensory abilities are intact, but remain alert for evidence that the patient might have some type of deficit. We don't want to assume that just because of the patient's age, they have a deficit. If the patient has suffered a brain injury, it results in permanent damage. There could be changes in cognition, their learning ability, their emotions, and their motor function. Typically, we see this with our patients that have had a traumatic head injury. Cerebral palsy is an umbrella term, and that's used for motor impairments that result from brain abnormalities that arise early on in development. The degree of impairment varies, but there's difficulty controlling muscles. There may be stiffness to the joints, as well as contractures. So most people with cerebral palsy demonstrate difficulties in controlling muscle function, and they demonstrate muscle stiffness and joint contractures. In some cases, there could also be a cognitive impairment. Brain dysfunction from head trauma is a debilitating injury that usually leaves the patient permanently dependent on outsiders for medical care. The dysfunction of the brain from the injury can result in problems in breathing, heart rate, and blood pressure regulation. They could have mild speech impairment to being completely unresponsive and ventilator dependent, where they can't breathe on their own. The ventilator is doing it for them. The care that we're rendering for our patient with a brain injury is going to depend on the reason why the caregiver called 911. It's all going to go back to airway, adequate breathing, oxygenation, and peripheral perfusion. If the patient has home technology like IV pumps or a ventilator, um, that's going to make the call an ALS call, unless the patient's caregiver is going to ride to the hospital with us. We're not allowed to um, transport a patient with IV fluid running, and we're not allowed to transport a patient on a ventilator. So if the patient's primary caregiver or caregiver is going to go with them to the hospital and be in the back with us during transport in case any of their medical devices fail, that's perfectly acceptable, but we can't take them without their caregiver. If a patient is paralyzed in all four extremities, they're said to be quadriplegic. If the patient with quadriplegia has a spinal injury in the vicinity of C3 to C5, or if they're suffering from a neuromuscular disease, they may not be able to breathe adequately on their home. If the patient's ventilator dependent, don't touch the ventilator settings. Just leave the vent settings as they are. But realize en route to the hospital, if it's an acute issue, you may have to suction the tracheostomy tube or their stoma. You're paralyzed. If the patient is paralyzed, they may also have a Foley catheter or a urinary catheter. It's important to keep the bag below the level of insertion, so any drainage in the bag doesn't travel back up the tube and into the urinary bladder. So don't allow necessary tasks and other specialty care distract you from the fact that you were probably called for some other emergency that you also have to attend to. But the family is usually very knowledgeable. Families are very knowledgeable about how to use the equipment, how to move the patient, how the patient is more comfortable when they're on the stretcher. So use those resources that are available. Bariatrics is the branch of medicine that deals with the management of obese patients. A person who's 20% or more over their ideal body weight is considered to be obese. If they're more than 50 to 100% over their ideal body weight, or 100 pounds over their ideal body weight, then the patient is considered morbidly obese. The way that you position your obese patient on the stretcher for transport can have a significant impact on how well they can breathe. You want to try to keep the patient upright or lowered no more than a semi-Fowler's position when you transport them. All that excess weight, if you lay them flat, the excess weight of the tissues as they move back and upward toward the diaphragm will actually compress on the diaphragm and compress on the lungs, making it more difficult for the obese patient to breathe. So you want to transport them in an upright position as they'll tolerate. An airway occlusion can be prevented by properly positioning the patient. If they're conscious, allow them to assume a comfortable position. Usually that's upright or in a slightly reclined position. If they can't protect their own airway, try to position the airway in at least a neutral position to allow for airflow. You can place some folded towels or bath blankets beneath the shoulders and the neck, and that will help to keep the airway in a neutral inline position. When the patient's supine, The posterior thoracic wall has limited mobility, and the anterior thoracic wall is weighed down by the patient's adipose tissue. So that's what causes rapid fatigue of the respiratory muscles. So this is why we're not transporting our obese patients flat. Um, if you do have to ventilate a patient that's obese, it's significantly more difficult to ventilate that patient as compared to um, your patient of average or normal size. If you do find out a little bit late that you have an obese patient that's having a medical emergency, like when you arrive on scene and see them, you want to call dispatch um, to send you a bariatric unit. Um, and that bariatric unit has a special stretcher um, that's designed to hold more weight, and it's wider than the standard ambulance stretcher. Um, there's also bariatric stair chairs to get the patient out of the house. They're bigger and wider than the standard stair chair to fit the patient in. You're probably also going to need um, a couple of engines and maybe a couple more ambulances, depending on how big the patient is or how heavy the patient is. Um, it's much easier to distribute that weight um, between 6 or 8 rescuers than it is to try to distribute that weight between 4 rescuers. The bariatric stretcher holds up to 940 pounds of patient. Um, the only problem is you may not be able to fit all of the patient on the stretcher comfortably. It holds more weight than it is wide. It's only about 3 to 4 inches wider than the standard ambulance stretcher, but it does have a higher weight limit. This is a fancy bariatric unit that has a track system that wheels the stretcher up and into the ambulance. Other bariatric units will have a winch on the back that will pull the stretcher in, while one EMT guides the foot end of the stretcher into the truck. Um, most services in Massachusetts don't have this setup. It's just a regular box truck with a center mount stretcher, which gives a little bit of extra room on each side to accommodate the wider stretcher. Um, but you're actually at most services in Massachusetts, you are lifting that patient into the ambulance with the help of 6 or so other rescuers. We do see a lot of frequent flyer patients um, that are homeless, or they're homeless for a variety of reasons: lack of affordable housing, substance abuse, mental illness. Um, Patients have also been forced out of their homes, but we do respond to a lot of patients that have underlying issues of mental illness as well as polysubstance abuse. Some issues that are associated with homelessness are an increased risk of both violence and abuse, um, a reduced access to healthcare, and an increased risk of illness or disease. Oftentimes when a homeless person has an emergency, bystanders call 911, and there's no address for you to respond to. So you'll get a cross street um, where two streets intersect, um, a park in front of the liquor store. So it makes finding the patient a little bit more difficult. Some places where the homeless might find refuge would be abandoned buildings, public places, vehicles, unoccupied houses, homeless shelters. Because of their exposure to the environment, as well as lack of preventative care um, or medical care when minor injuries or illnesses arise, um, homeless population is at a high risk for emergencies. Then there's the ongoing conditions like poor nutrition, environmental exposure, lack of access to medication, and vulnerability to violent acts, which leaves them at a risk for cardiac, pulmonary, vascular, and traumatic emergencies. Patients that live in poverty, that fall below the poverty level, are at a greater risk for illness and injury, partly because it's from their environment, and partly it's from the lack of primary care, including screening and treatment needed to prevent the advanced development of disease. There are times where patients that are below the poverty level have to choose between buying medication for themselves um, or buying food for the family, or even paying the electric bill. According to the National Human Trafficking Resource Center, human trafficking is a form of modern day slavery in which traffickers use force, fraud, coercions to control victims for the purposes of engaging in commercial sex acts or labor services against his or her will. Sex trafficking is the recruitment, harboring, transportation, provision, obtaining, patronizing, um, for purposes of a commercial sex act in which the commercial sex act is induced by force, fraud, coercion, or which the person is induced to perform such acts and has not attained 18 years of age. So some common characteristics of human trafficking victims would be runaways or homeless youths, victims of domestic violence, sexual assault, social discrimination, or victims of war conflict. The victims don't seek help because they might not speak English, um, they may not have identification or money, and may not even have any idea where they are because they're moved so frequently. Some common settings: escort services, the porn industry, massage parlors, ranches or farms, factories, nail salons, home cleaning, and hotels. Some victim characteristics: they're controlled physically or psychologically by someone at the scene. They don't have the availability to leave. All the history information is provided by someone else. They're not able to produce any identification, and they have a lack of personal items. The victim may also not have any sense of the current day or time, or even the city or state in which they're currently in. Many traffickers will convince their victims that if they do escape and report them, they'll find them and harm the victim or their family member and friends. There are some psychological as well as behavioral clues that will help to identify a victim of human trafficking. If they exhibit a feeling of hopelessness, self-blame, humiliation, eating or sleep disorders, if they're addicted to drugs or alcohol, they appear to be emotionally numb, or if they show evidence of trauma bonding with the trafficker. The victim can also present with signs and symptoms of denial, post-traumatic stress disorder, phobias, panic attacks, anxiety, or depression. Trafficking victims can also present with chronic illnesses like diabetes and cardiovascular disease that are untreated, sexually transmitted diseases, UTIs, pelvic inflammatory disease, and genitalia injuries from sexual assault. Your emergency care is going to revolve around making sure that your scene is safe. Provide any emergency care for the illness or the injury within scope of practice. Um, if the patient does not allow you to transport them, you can contact local law enforcement. So basically, see something, say something. So now we have our technology dependent patients. Um, Most of these patients at one point required hospital care, but now they can be cared for at home. And that's in part due to medical technology. Um, the technology is either life enhancing, meaning it makes life better, or it's life sustaining. It keeps them alive. Even though as an EMT, you probably will not have seen the particular type of medical equipment that's found in the patient's home. Um, as the EMT, you'll be expected to be able to troubleshoot it and support any lost function of the patient should the medical device fail. Oftentimes, the top three reasons that we get called to the patient's house is number one, the equipment failed. The family has tried all the troubleshooting steps in the world. They even broke out the instruction manual. They called tech support, and the equipment still won't work. Second is another change in the patient's clinical condition, um, or they're experiencing some other type of an emergency. The family members of the care providers are going to have extensive knowledge of the medical devices that are found at the home, so take them for face value. They're with that person and that equipment far longer than we are as EMTs, so they're going to have reliable information on how that equipment is supposed to work and how the patient normally responds to it. So our first step is determining what the medical device is supposed to do for the patient. How critical is that function to the patient's survival, and what type of impact the device has, if any, on other medical or traumatic emergencies the patient may suffer. So although much of the equipment you see in the patient's home is similar to what you would see in a hospital setting, there's usually a difference in the size and the complexity of the device. Um, Usually the tertiary centers that implant the devices have resources available. You can call a number and you can get a consultation regarding how the device is supposed to work and troubleshooting steps. But basically, you need to ask yourself some questions. Number one, where can I get device information? Keep it simple. If the device is in the home, there's a sticker on it with a number to call. Start there. What does the device do? And can I replace the device's function if it fails? Will the medical device that the patient is using have an effect on the assessment or findings? Just like our medical history, the medical assessment in our history, we would ask the patient, has this problem ever occurred with the device before? How was it fixed? And has anybody tried to remedy the issue? Sometimes people get freaked out because the device is malfunctioning, and the first thing they do is they go into panic mode and they call 911. So we want to try to establish if the basic troubleshooting steps have been tried and what the outcome was. If our patient is dependent on technology, there are some tasks that we're going to focus on. Keeping their airway open, making sure that we have established and we're maintaining adequate ventilation. maintaining oxygenation, maintaining adequate oxygenation, and supporting cardiovascular function. If you provide that care at a minimum, you're going to ensure the patient's best chance for survival, regardless of the immediate emergency and the patient's dependence on medical technology. So in summary, we discussed how patients can present with a variety of challenges like sensory impairment, obesity, poverty, and homelessness. We have to be understanding and in the needs of the patients and the variations in assessment findings and emergency care. And then lastly, we discussed the home medical devices are becoming more commonplace. And the patients, as well as the caregivers, are great resources for how to use the device, how to troubleshoot. And we also discussed supporting the patient's lost functions and intervening with our equipment only if there's a malfunction of the patient's own equipment. So this is the end of our patients with special needs or special challenges. Group A is going to meet on Sunday at 9 a.m. The address is 109 Madison Street in Malden, and I'll be sending that out in an email very shortly. Group B is going to meet at 1:30 in the afternoon on Sunday, same address. Group A is 9 to 1, and Group B is 1:30 to 5:30. We're going to incorporate the operations lectures into skills because that makes it a little bit easier to understand and put together. So we are all done with the didactic portion now. There's no more GoToMeeting. The rest of our meetings will be in person at the Education Center, and I will see everybody on Sunday.
Hey, Mark, what do we need to bring for Sunday?